I would like to say hi to our distinguished guests and fellow members. I am Yoon from Acro Dental Clinic. I'm going to discuss fenestration, which can occur during implant treatment, and GBR, using surgical methods for dehiscence. GBR for fenestration, fixed membrane treatment using bone tack. Dr. Yoon, Director, Acro Dental Clinic. This 31-year-old female patient has worn a temporary denture since the extraction of her 2 maxillary central incisors 15 years ago. Thus, severe recession is expected in the alveolar bone. Since the alveolar ridge was wider than I expected, I will perform implant grafting first. If reverse recession occurs in the apex and periapical area, I will perform GBR, or guided bone regeneration. Arguably, the incision on the palatial side, not at the right center of the crestal side, helps prevent subsequent dehiscence. A 1.5 millimeter attached gingiva is required at the very least to prevent dehiscence without causing damage due to muscular tension. For the incision method, the most commonly used is wide, remote, and vertical incision, crossing over one tooth or 2. With this patient, however, the flap was built first without vertical incision, since I didn't know the state of the wound. As you can see here, implants should be grafted in the precise place using a custom-made surgical stent. In particular, the most important thing for the anterior maxilla is the platform position of implants, since it will determine the aesthetics of prosthesis. I did an initial drilling using a guide drill made by Ostem Implant and included in the Hanaro kit. Drilling needs care. Labioversion should be avoided. In particular, indentation of approximately 2 millimeters at the joint of both teeth will make for an aesthetic prosthesis later. One thing to remember is that although the handpiece head is now out of the way, most heads will get stuck in the teeth. As such, I recommend using a drill extension for convenience. A 2.0 twist drill is used for the initial drilling. The direction will be examined using parallel pins. As you can see, I am using a drill extension and a side cut drill to change the direction. At this point, make sure that the drilling point is neither too far from the adjacent teeth nor too near the center during drilling. In fact, judging during drilling whether fenestration occurs outside is very difficult. As such, drilling was done consistently while avoiding opening the flap as much as possible. Since the ridge is quite narrow, I will do implant grafting first, followed by augmentation in the exterior. Be sure to use a stent to check the precision of the position, as what I'm doing now. For the implant position, the prosthetic margin in the future should be considered. With GS2 implants, should ideally be placed on the posterior 3 to 4 millimeters from the margin of an expected prosthesis. Before that, however, I will predict the position of the implant platform using a surgical stent. I'm grafting a GS2 implant with diameter of 3.5 and length of 13 millimeters. At this time, take care to not pull this implant outward to avoid labioversion. Note the 3 to 4 millimeter allowance in the posterior from the margin of the expected prosthesis. It is important to examine the precision of implant depth using a stent. I am going to place the implant more deeply using a fixture driver in the Hanaro kit. Since augmentation will be done in the exterior area, I will use a cover screw to make a submerged type. I will now perform a vertical incision for smooth release. Since fenestration was detected during drilling, I am going to make the flap wide enough and expose the fenestrated area. At this time, make sure that the fixture surface does not come into contact with a periosteel elevator. According to the Tinti classification, it is a Class II defect formed in the exterior of the bone envelope. In other words, it is a wound that hampers space maintenance. Thus, in this case, using a non-restorable membrane, such as partial bone graft or Gore-Tex for GBR, is recommended. This area is exposed, but it is a defect inside the bone envelope. This means easy space maintenance. According to the Tinti classification, This is Class 1 fenestration. In this case, you can use autogenous bone chip only. For a more predictable result, however, using something like a reversible membrane is recommended. I perform decortication to obtain better blood supply and better BIC. This is allogenic bone. For this area, autogenous bone is not required. In particular, I plan to use non-resorbable Gore-Tex membrane. Thus, I expect to get the same result as that in Pionelli's paper in general, regardless of the bone material. I mixed it with PRP for much easier bone manipulation. Trim the Gore-Tex membrane into an appropriate size and then fix it using a bone tack. For areas where space creation and maintenance are difficult, fixing the membrane is safer. You can also get a predictable result. I will now fix the membrane using a bone tack. In GBR surgery, the two most important goals are having the membrane maintain the space and promoting the primary intention healing. In case of wound dehiscence, and if early exposure occurs in the membrane, less bone may be gained, according to some researchers. Therefore, one of the most important factors in GBR surgery is good primary closure, as what I'm doing right now. I will do vertical mattress suturing as the key suture and remove the dead space. I will also try to form an even margin. If tension occurs in the flap, it is important to perform tension-free suturing through the proper use of vertical incision and periosteum-releasing incision. In other words, getting a tension-free primary eversion closure is a must. This is a radiation view. As you saw during the surgery, severe recession occurred in the periapical area together with fenestration. As such, implants were grafted. For the fenestration, bone grafting and GBR were done. I think a second surgery should be done after about 6 months.